Hi, everyone. Welcome. Don't be shy. Come to the front. Take a seat. Join us. Hi there. I'm really excited with all the different panels going on right now. You've chosen to come here and be with us for this important discussion. So I'd like to get started. And to start, I'm hoping that each of our panelists will introduce themselves, tell you a little bit about the work that they're doing and the organization that they represent. I'll start with you, Dr. Zumarraga.
Hi, good morning. Thanks for coming. My name is Jennifer Zumarraga. I'm a child and adolescent psychiatrist, and I work at Camino Hospital in the Aspire program. I'm the medical director for child and adolescent psychiatry there. Our program is an intensive outpatient program. So just to kind of go over quickly the continuum of care that we have in the community, we have outpatient, so that would be when someone sees a therapist or maybe a psychiatrist once or twice, in a month, or maybe more frequently. And then our level is the next level up, which is IOP, intensive outpatient. And so what that means is they come to our program. For ours, we have 3 days a week to 4 days a week. We see a range of kids. So our ages run from 12 to 25, and we have 4 different programs. So wanted to briefly go over our programs. We see middle schoolers, and then we see high schoolers. We see young adults, and those are after they graduated from high school to age 25, so they're just launching into the world. And then we also, our newest program that we opened up is a dual diagnosis program. So for high schoolers that have addictions, and that could be to screens or that could be to substances, and they have a co-occurring anxiety or mood disorder. So those are our programs. They're pretty intensive. And then, so that's the second level. We have a higher level that's, even more intensive that we're working on trying to start. That's a PhD, that's 6 hours a day. And then above that, there's the inpatient hospitalization and I'm just explaining what's out in the community. And there's also residential treatment. So we come in and we get kids from the community, from outpatient, and we get kids from more acute settings that are referred to us. So basically that's what we do at El Camino in the Aspire program. Want to tell you just really briefly also about how we work and what our frame is. It's basically a skills-based program. Our frame is dialectical behavioral therapy, and we want to teach our youth skills that they can use for the rest of their lives. So we're here to teach them some distress tolerance. We want to teach them mindfulness and interpersonal effectiveness. So these are things that we want them to be able to learn and gain confidence that whenever there's anything that they're going through, that they can use these skills to get through. So that's basically what our programs are about. We work with parents to help them to build a better relationship and to learn how to support their teens and to also, their learning skills also, so they can coach their kids too. So I am going to turn this over to you.
Thank you. Good morning, everyone. My name is Marico. I'm the Executive Director for CASSY, which stands for Counseling and Support Services for Youth. We're a nonprofit agency that started in 2009, and we place mental health therapists on school campuses. We're in both public and private schools, as far north as Millbrae and as far south as Gilroy. And basically, we provide the mental health support that many of our schools are now responsible for. And we placed registered MFTs, marriage family therapists, or social workers on campus. And by being on campus, our goal is to destigmatize mental health support and then just be and meet students where they're at. We are working with preschoolers. We have 2 preschools in Menlo Park and all the way up until high school. And our goal is to really be available. So we ask no financial questions, we take no insurance, we ask really nothing and try to eliminate barriers that families are seeing and that prevent them from having support. Our biggest, our practices vary depending on the needs of each school, and it does vary depending on the culture of the community. We provide individual counseling that can be weekly based on the assessment and the treatment plan that a student and family is working on. We could do group counseling. Elementary school, we tend to see that's more successful. We also do crisis support, risk assessment, safety plans, and when we do have patients or students that are Aspire programs that are ready to re-enter into the school environment, we work with them as well as Aspire to really make sure that while they're on campus, they have that support as well. For families, we work with the parents so that if there are concerns, we have that consultation with parents, and more we're doing more parent engagement, parent education, parenting skills, more of the preventative work that really escalated after the pandemic. And then by being on campus, we do a lot of psychoeducation with staff so that if there are concerns, we are available immediately to come into a classroom and just really be a partner to the school community as they try and support their children, their students. It's a tough time, as we all know, and I am really looking forward to the conversation.
Good morning, everybody. My name is Andrew Kotch. I'm the Assistant Program Manager for the Trust Team for North County, provided by Momentum. What Trust is stands for the Trusted Response Urgent Support Team. It's the newest mental health mobile response team for Santa Clara County. 3 providers are involved in this program. Momentum's covering North County from Santa Clara up to Palo Alto. Pacific Clinics is covering San Jose as well as South County. What we're doing is we're meeting individuals where they're at in the community, providing de-escalation, coping strategies, and things like that. We're triaged through the 988 hotline for individuals experiencing crisis. We don't respond with law enforcement, which is the main part of this program. A few years back, the community called to action that we want to approach these situations in more of a behavioral health way and eliminate individuals being entered into the criminal justice system, given their situation. So when we're out there in the community, responding to individuals in home settings or the unhoused, throughout the community, all that we're doing, it's almost very simple. We're providing a human-to-human contact for individuals, giving people a safe space to express themselves and express the crisis that they're going through, in hopes that we can bring them to a baseline so a higher level of care isn't needed, and they can continue with their day. We're seeing success in this, just given the makeup of our team. We're staffed with a first aid responder who's a licensed EMT but is operating on more of a lower level scope of work. We have a crisis intervention specialist on our staff as well who's providing de-escalating techniques, coping strategies, stress management, and then we have our peer navigator. And I'd like to highlight that position very strongly, the peer navigator. It's an element of our program that's going a long way in the community. Somebody with lived experience who's not approaching these situations in a clinical way, but is offering help to navigate the mental health system, offering support in a crisis that they've also gone through themselves, and ultimately the client responds to that more in a positive way. It's somebody on their playing field. They begin to build rapport with them, and we're able to take the next steps in our engagement with the individual. So we're seeing a lot of success with the peer navigator role in this program. This is a pilot program that's launched in Santa Clara County. So when the program was launched, they've identified vulnerable areas throughout Santa Clara County, certain zip codes that were being dispatched to more regularly. And from there, proving the concept that this model does work non-law enforcement related, and taking this more non-clinical approach to assisting these individuals and getting them to the next step. Another part of the contract that's very unique to this program as well is within the first 24 to 48 hours of a dispatch, we provide follow-up care. Meaning we either go in person to the family or individual, or we give a phone call just to show that extra level of care to the individual. Hey, did you make it through your night? Are you doing okay? Do you need additional resources? Kind of showing that support to them throughout their journey. So it's a new program. We're only 5 months in for the launch. So we're still getting the word out, but it's good to be here, and thank you all.
Thank you, each of you, for your descriptions of the work that you're doing. So much has changed in the last couple years. I'm wondering if each of you will take a moment and tell us a little bit about the needs of each of the population that you're serving. What's changed? What are people really coming in to you to talk about? Give us a little bit of insight about that.
So I came into Aspire. We started it in, we started thinking about it in 2009 after a series of suicides. And we brought together a task force. And we had some high school students that were part of the task force as well. We decided that putting together a program to help them with skills that they can use for the rest of their lives is the direction that we would be going in. At that point, it's interesting because I have a perspective from 10 years ago when we started it. I actually left the hospital in 2014, I think, to do some other things in the community. And then I returned a couple years ago. And there's a huge difference that I'm seeing. So I have a unique perspective of leaving and then coming back and seeing the difference in the types of patients that I'm seeing. I do think that they are much more acute. We're getting them further along in their illness than I'm seeing. There's much more suicidal thoughts and plans. There's a lot of self-harm that's happening and a lot of school refusal. They're just not able to function the way that they used to or the way that they want to. And so the acuity is a lot higher now, for sure. And so that's one of the things that I'm definitely seeing. There's a lot of stressors and increased stressors on our kids. I think the pandemic was very difficult, and that led to a lot of isolation and difficulty even coming back to school for a lot of kids. So I think the fallout from the pandemic is still something that we'll keep seeing some residual effects from over the next several years and more. So that's the biggest difference that I'm seeing right now.
I definitely agree with acuity, and one thing I'd add is it's happening at a much younger age. I think as an administrator, we place our highly skilled therapists that are more crisis-oriented on high schools, and we've had several crises now at an elementary school. And so I think that's something that is significantly different, and for those that are entering the profession to acknowledge that even at an elementary school, having that crisis ability is key. What I also find interesting is that the level of engagement is higher. So that's the negative, but the positive is that the number of students and families asking for support has increased, which we think is a wonderful thing because we're trying to help support. School-based is very unique, and we're trying to be more preventative so that they don't get to the Aspire level. And we're seeing more and more of those requests. So that's a positive thing. Obviously, what's difficult are, do we have enough resources to meet that? And I think that's where a community could really engage of how do we make sure that we have that, so that when there is that call for support that we have. The other interesting that I'm also finding is that there are more and more diversity in therapists seeking this profession. In the past, I'd say pre-pandemic, we were starting to see the stigmas in certain cultures, but we're starting to see that slowly dwindle as all of us acknowledge that mental health support could be, we all need it, and it's not limited to any one segment of a population. So the good and the bad.
Yeah, for the trust program, we're seeing changes on both ends, like I said, with the unhoused community as well as individuals in home settings. One thing that we've been seeing with the unhoused community is not only responding to mental health crises in the community, but we're also responding to crises related to substance use as well. And that's definitely playing a role in some of the dispatches that we're going on. And, you know, to the change in that, you know, it's ever growing. And it's this thought with, you know, that the community might see as, you know, that individuals, you know, experiencing these crises in the community are a danger to others around them, a danger to themselves, but really that person just needs someone to talk to. It's kind of like that stigma related to this work, that that person's violent, that person needs, you know, the police need to be involved, but it's really just to bring that individual down to a baseline. So all these factors that are being played into this, we're seeing changes, as well as the simple basic needs being met. So individuals who don't have access to showers, proper nutrition, hygiene, you know, you go that long without those basic needs, you're going to start to develop a crisis, or you're going to be in crisis at some points. That if those needs are met, and you know, like we're saying, is the access to resources, that can go a long way for an individual to help them, you know, go about their day after a 15-minute hot shower at, you know, a shower trailer, Dignity on Wheels, things like that, to improve their day in hopes that that will get the ball rolling for them to continue with that and have a helping hand along the way. So we're seeing now the unhoused community, bit by bit, also that kind of revolving doors. We're dispatched to an individual, say in downtown Mountain View, we get them the help they need, and then the next week we get another call for that individual back in the same location. So it's hard to, you can kind of work with that. It's, you know, how do we support this individual in a greater way to get them, you know, the resources if they wish to accept them. And with, you know, individuals in home setting, we get dispatched to a lot of families calling for loved ones and things like that. And we're seeing that, you know, individuals are experiencing a lot of new crises, right? I'm experiencing these thoughts for the first time, and some family members don't really know what's going on with the loved one. They start to panic, and you know, we get dispatched out. It's a lot of educating everyone involved with this, of that, you know, instead of the police coming to respond to these situations, you know, when police arrive and you might be having, you know, depressive thoughts and things like that, you think that something's wrong, and that you're going to be punished for these thoughts. Really, we just go there and support the guardians that are there as well as the client that we're dispatched to, and saying, you know, we're going to hear you out. There's nothing wrong. We're here to support you. We're going to talk through these things. And so a lot of new crises forming in home settings, just providing knowledge, education, and the resources to these individuals to help them, you know, go about it and, you know, enjoy their daily life.
I'm wondering if each of you can speak a little bit about the different barriers to care, both access to care, the differences in equity and access to care, not only financially, but maybe the stigma associated with seeking out services.
One of the biggest things that we've come up against, and especially when they come into the program, is trying to find care for them after they leave the program. It's really very difficult to find therapists that are taking new clients, and psychiatrists that are taking new clients. It's something that we're trying to figure out, how can we be a support for the community within the hospital so it's not as difficult to do that, just so that there is a continuity of care that doesn't get lost. I think that's the biggest thing that, and the biggest frustration really, is not having a quick continuity of care that happens right after they leave the program. So as soon as they hit our doors, I'm saying, okay, wait, we need to make referrals now. And our programs are over 2 months. So sometimes it takes that long and even longer to find, you know, somebody that we can pass on the information of how this child has been doing in our program, and so that they don't have to start all over again with their story. I think that's one of the barriers. I do see a lot of times where there are lots of kids that are very ill, and parents can't force them to come in. And so that's the hard part too, is that wanting to provide education on how to set limits and boundaries for parents to get their child to come into treatment. I do see a lot of kids that are very, very education focused. And so their worry is like, I don't have time for a program. I don't have time to do treatment because I have to study and I have to go to school and I have to take all these APs. And it's so hard because it's like, oh gosh, but you could do all that much better if you felt better. So that's another barrier. Just getting the news out to them. I really appreciate the work that CASSY does too, because I know there's a lot of work that goes into the schools. So those are a few of the barriers I see. I'm sure there's a lot more. Thank you.
Thank you. Thanks for the shout out. One of the things I love about CASSY is we try to remove the barriers. Again, we are on a school campus. We ask no financial questions. And one of the most beautiful things is oftentimes we will be the first time a student or child will meet a therapist. And it places a lot of pressure because it could be a make or break situation. And so that's one of the beauties of school-based counseling. Now, there are lots of issues that should not be addressed on the school campus. And so when that is assessed, and when a therapist does intake, makes an assessment, that's where we help navigate through the system. What are the outside resources that we can send the family to? Unfortunately, because there is a lack of therapists, we find that we keep them on our caseload longer, which is fine, but then that starts to build up a waiting list. And so I think that's why you're starting to see schools feel the weight of school-based counseling, because as families continue to look for outside resources, whether or not they can afford it, there are just no resources available, and so the schools are now being held responsible for providing the mental health support of their children. So I think that's something that I think as a community and as all of us, we really need to address. I think for my staff, constantly knowing what resources are available, at what level, trying to help families just navigate through that system. But for any family that's always just in doubt, I ask them, just call, because that's our job to figure this out as a parent. When you're concerned about your children, the last thing you need to figure out is which door, which phone, who do I call? And that's really our job to help you navigate through that system.
Yeah, with regarding trust, just to briefly touch on the barriers to access our services, the only barrier to access the trust team is being an adult, 18 or older. We don't look at insurance, you don't need private insurance or anything like that. Really, you just have to call 988 and then be transferred to our call center and be dispatched. So that's one of the good models about trust is the very low barriers of entering our services. But kind of how we touched on earlier is one of the barriers that we're coming across now is, given we're such a new program, getting the word out, most definitely, and portraying to the community that this is an option to be taken. As the past 5 months have gone on, we're doing a lot of community engagement with other organizations and providers within the county, but really it's taking that next step to get the community members in our smaller communities, in your neighborhoods, that when you're seeing things go on, that 988 is that option for you, right? And it's going to take time to have that change of pace from going from 911 to 988 for those low-level center calls that were dispatched on, or even pre-crisis situations, right? But ultimately, it's going to take time, like I said. Resources are playing a big part in it as well. We provide transportation on some dispatches to shelters, sobering centers, Momentum's crisis stabilization unit down in San Jose, and sometimes, due to a shortage of beds at shelters, it's hard to get a transport done, right? And sobering center, same thing. And some of these places, it might be you have to be out at a certain time in the morning. So if you have an individual that we're coming into contact with at an RV who's willing to go to a shelter, but they're afraid to leave all their belongings behind. So a lot of these barriers, what do we do with those individuals' belongings that they're calling, home and theirs, which we need to respect, but also giving them a safe place to sleep that night. So just barriers popping up here and there that we're trying to work around and help individuals with.
Thank you. So I have a couple questions for each of our panelists individually. They each bring such unique experience. So Dr. Zumarraga, I'm going to start with you. I don't know if any of you have seen the news lately, but the CDC recently posted some new data regarding a mental health epidemic in our teen girls in particular. The data states that nearly 1 in 3 high school girls considered suicide in 2021. That's a 60% increase since 2011. More girls are also now reporting feeling so sad and hopeless that they couldn't engage in their normal activities for at least 2 weeks in the last year. I'm wondering if you can talk to us a little bit about this and what you're seeing and maybe some advice you have of how we can support our teen girls.
When I was looking at preparing for being here, I did go back and look at some of the studies that the CDC put out. That was in February, I believe, of this year, and it was very alarming. There was definitely an uptick during COVID, and there was also a steady increase even before COVID. So we could see that there was more isolation in girls. I don't want to blame everything on this next thing that I say, but I think that there are a lot of other issues that come from social media. So it is not uncommon for me to talk to the kids, and they're on their screens, 4, 5, 6, 8 hours a day. It's incredible how much they do. And what that means is, they're getting inundated with lots of different things, lots of different ideas. That also means that they're not out socializing and they're not out playing and sleeping and eating and all the basics. All of that is getting taken away. And so I do see that. They also, and more in particular, I think the girls, they're looking at different things than what the boys are doing. Because the boys are most of the time playing. They're playing games, and that's a way for them to socialize. In the studies, the boys pretty much stayed, their curve actually stayed flat. So I believe the suicide, the thoughts of suicide was at 14%, 13%, and it rose to 14% from 2011 to 2021. And then for girls, as you can see, it really jumped. So the difference too is that the girls are also looking, they're comparing. It's a no-win situation when you're comparing because, it's not realistic what they're seeing. So that's one of the things, and trying to figure out how to get them to see it, because it's really hard for parents to take screens away because it's, the kids do use it as distraction and they use it as some connection, and so there's those positive things, but then it's also really hurting them. And so trying to figure out how to get them to see it, that this is, that this is an issue. So that's,
So Marico, you're an administrator, and I think all of us here would agree that we would love to see more CASSYs all over the county and all over the state and our nation. But tell us a little bit about what your challenges are in meeting this high demand, and why is it that we can't just have more therapists out there doing this work that's so needed?
Thanks, it's a great question. And our biggest pain point is therapists. And I'll give 3 examples, and many of you can relate to this. During the pandemic, we all heard about frontline workers. They were celebrated, they were our heroes, but we forget they didn't have time off. They had children themselves. Half of my staff during the pandemic moved away. Once telehealth became more prevalent, they found that there were more affordable places to live. predominantly therapists are female, and so they left because there's lack of childcare. And then I had another 25% that are just burnt out. And so just to give an example, when you are working with a student, whether it's Aspire or on a school campus, when you're in crisis, you stay with them sometimes till 9 p.m. And in a normal setting, you would give someone the time to process the next day. They received the angst that child was experiencing, and we send them back to work, not giving them time to process and work through the feelings that they just received. And so it's just a continuous burnout situation. And I know we could talk about that with teachers and nurses and doctors, but until we really think of how we can give them the space to heal from receiving that trauma, I think we're going to continuously see burnout, and it's a spiral.
Andrew, you're running mobile crisis teams, which is a critical resource for our county and meeting the needs of our community members. And you've mentioned a couple of times about the role that police can play in mobile crisis. Can you talk to us a little bit more about that? What role, if any, should police play in mobile crisis response?
Yeah, with the trust program, given the main part of the program is non-law enforcement related, we do understand that we might be in situations where calls need to be escalated, right? So in the process of launching this program, we are forming relationships with other mobile crisis response teams that are joint response. So your mobile crisis response team, MCRT, clinicians come out alongside law enforcement. That's like our first step to take with those individuals. And then if the situation is being escalated a little further, 911 is somewhere where we need to go. Granted, we haven't had to do that yet, but I think something has to be said about our staff's own safety as well. Being in these situations, when we're dispatched, we don't really know what we're getting into. That's the kind of the world of mobile crisis response. You don't know what's going on in the house that you're being responded to, whether there's firearms registered there, whether someone has a warrant there. No information is being provided. So we train our staff with safety precautions, but we do realize that in those situations, law enforcement might be needed, where we go to a house and things aren't looking too safe for our staff, and we don't want to put them in jeopardy, and we need a higher level of care there to support us. The other side of the relationship with law enforcement with us is that handoff that comes down the chain. When law enforcement is out on a call and they're realizing that it's lower acuity than what they needed to be on, and their efforts might be needed higher somewhere else in the community, that they're willing to step the call down to our team, pass over the information. So it's a two-way street going back and forth that we're working out with more of like a mainstream communication with them, but for both parties to understand that, yes, our efforts are needed in each respectable way, whether it's the trust team or law enforcement in certain situations, and from there, going to build that communication with them.
Thank you.
Thank you to each of our panelists and to the Community Foundation for putting this on.